Okay, I guess we should use this too. Okay. All right, so this topic is 6 commonly asked questions regarding breast augmentation. And here we go. That is up to the patient and up to the surgeon. And in my practice, 95% of the time, patients are seeking natural appearing results. That's what we call LA natural. Now, keep in mind, I perform thousands and thousands of breast implant operations. So I do everything from the very smallest implants to the very large implants, to primary cases, to multiple revision procedures and everything in between. Most of all, I want to communicate clearly with the patient and understand what she is seeking. But I believe also a lot of patients seek me out because they see I'm not afraid to use a conservatively sized implant to get a beautiful and natural result. Things that I'm going to want to do are not exceed the skin elasticity of a patient. A mom who's breastfed multiple patients is going to have more skin elasticity than a 24-year-old. We need to account for that when we're choosing the implant size. We want to be very strategic in choosing the dimensions of the implant, whether it's a low profile, high profile, moderate profile, or somewhere in between implant. That's going to depend on a combination of things: the overall chest diameter, the width of the actual breast, the amount of skin elasticity, and the size, the volume that the patient is seeking to achieve. I spend approximately an hour with each of my new patients discussing these things in detail, and even more time at the preoperative visits. I probably don't need to spend that much time with them, but honestly, it's fun for me. I think patients value it, and at the end of the day, we're going to get that beautiful result they're seeking, especially if it's LA natural. Hit me with question number 2. I'd say 99.9% of the breast augmentations on female patients, but occasionally we will do that on male patients who are transgender, becoming female. And we also do pec implants occasionally on patients who are male, who want to have a more defined chest. But for the mainstream female patient that's coming in to see me for breast augmentation, I would say number 1, somebody who wants to be a larger breast size. It's important to differentiate between a breast lift, where we're making them high, tight, and perky, but a similar volume, from where we actually want to increase the cup size of the breast. We want to have adequate skin elasticity to achieve a nice looking result. If the patient has very small chest, very small breasts, and very tight skin, they're going to have a less natural appearing result if they strive to achieve a much bigger outcome, such as a D cup from an A cup than a C cup. They can still be a good candidate, but I'd say not as good a candidate as somebody who would naturally fit into that scenario. This again is a highly customized procedure. Defies a short enough answer for me to be able to answer in this video, but I guarantee you one thing: if you come in to see me in a consultation, I will go over the specific details with you about why you are a candidate for this procedure if you are. Hit me with question number 3. In my practice, I'd say about 95% of my patients prefer the silicone implants. In general, the cohesive gel, latest generation gummy bear implants. They're highly unlikely to rupture compared to older generation implants. They have fewer complications, fewer problems, fewer revision surgeries, a more natural feel, less rippling. There are a lot of positive things to love about them. One disadvantage is they are a little bit more expensive. Another disadvantage is there's been a lot of talk about silicone over the years and whether or not it is safe. Fortunately now, more than approximately 60 years after the first breast implants were performed in the early 1960s, we have a large body of evidence reviewing outcomes on patients. And although there is much more to learn, and we need to continue to study these implants for safety, we know that these implants are safer than they've ever been before, are extremely popular still and ever since 60 years ago when they were started. And I think there are a lot of reasons why patients could feel comfortable about them. That being said, no implants are perfect, and there are pros and cons to each. For those patients who are in a tighter budget perhaps, who are just anxious over the general concept of having a silicone implant, they might consider going with a saline implant. Now, saline implants first came out when silicone gel implants were pulled off the market 25 years ago or so. Saline implants don't feel as realistic as silicone gel implants. In a thin-skinned person with not much breast tissue, can feel a little bit like a water balloon. If you have really thick tissues over it, though, you might have more difficulty telling the difference. If a saline implant ruptures, it's just saltwater saline. It's the same thing that's a component of every cell in the body. It's what's in IV fluid when you go to the hospital or have an operation. So there's no worries about that safety at all. Versus a silicone gel implant, if it were to rupture, it doesn't just disappear like a saline implant, but it sits there and can kind of inflame and irritate the surrounding tissues. So a silicone gel implant requires some monitoring about whether or not it ruptures long term, whereas a saline implant is blatantly obvious. If it ruptures, it goes flat within a few days, and we get an urgent call from the patient asking for an emergent removal and replace. It's not really emergent. You can leave it for years that way, but to most patients, it seems pretty emergent to replace that implant as quickly as possible. The bottom line is, in general, I prefer the latest generation cohesive silicone gel implants, otherwise known as the gummy bear implants, but in specific cases, saline implants may be appropriate, and we still do those too. Hit me with the next question. And that is an important thing that we discuss in our consultation. Now, I'd love it if the patient has thought about it. First of all, what size are they now? What bra size do they wear? What size do they think they're going to want to wear after surgery? It's great if they can bring in a few pictures showing me what they like. I prefer nude pictures because you can really see. A lot can be covered up in bikinis or in dresses, but either way, I like to see the vision that they have for themselves. It's important when we communicate that the patient use patients of similar body habitus. For instance, if they have a wider chest or a narrower chest, a taller torso or shorter torso, thicker tissue, thinner tissue, it's important to compare apples to apples to have a relevant goal for this particular patient. This is something that I have fun with because I love talking to patients. I love trying to figure them out, what they're looking for, asking them key questions to distill it down to some even more precise questions. So after I listen to a patient, hear what they think they want, I examine them, give them feedback about the range of sizes that I think they can look beautiful in. There's usually not just one size for them, but there is an optimal range. If you go outside of that range, it's probably not going to be ideal. So I educate them about that. We come to a common agreement, and I show them examples of other patients of mine with similar body shapes and sizes, with similar goals in how we achieve them. Through that collaboration with the patient, they feel heard. I'm definitely communicating clearly with them, and we have a preliminary result. At the pre-op visit a couple weeks before surgery, we repeat that conversation again to make sure we've got the right implants. Hit me with the next question. And the answer is sometimes. It depends on how the breast is sagging. If the breasts are very droopy, the implant is not going to be able to lift everything up. If the breasts are a little bit droopy, it can be very effective, especially on patients who have what we call pseudotosis. Now, ptosis is droopiness of the breast when the nipples start to point down. Pseudotosis is when the nipples stay up, but the bottom kind of drops out on the breast. There's a key difference in there because it's hard for the breast implants to really raise up those nipples very much. You can get a little bit of elevation, but not much. The thicker the breast tissue, the less impact the breast implant is going to have on it. So on a very slender patient who's had multiple babies, has very thin tissue here, that implant is going to be pretty close to the surface of the skin, so it's going to have more of an effect and more of a lifting. On somebody who has larger, heavier breasts, the implant is going to be farther away from the skin, so it's going to have less power to do that lift. The other key thing is the size of the implant. If you go really big, it's going to create more lift, but sometimes in an undesirable way. What I like to do is, with the patient, educate them about their options and try to understand what size they're really looking for. In general, I don't think it's a good idea to go much bigger than your desired goal of a size in order to achieve some lift, because eventually they usually come down anyway, and if you're going to need a lift anyway, often it's better to bite the bullet, do it sooner. And it would be difficult for an individual patient to know this without a detailed consultation with a surgeon. But this procedure, combining breast lifts and augmentation, is an area of great expertise for me. You can see that on my website from the photo gallery. You can also see it in the many publications I have on this particular topic. And it's something that I enjoy discussing with patients to help them make a smart decision for themselves. Do you have any more questions for me today? You know, over the years, and over 20 years of private practice and so many thousands of breast implant cases, I've developed a technique that we have coined the term rapid recovery breast augmentation for. Why? Because it is truly rapid recovery. Now, in truth, there's variability in recovery. It isn't always a one-day recovery and back to work, but very often, more often than not, that is exactly the case. And check out some of the YouTube videos on our YouTube page or on our website. You'll see some unbelievable results where patients literally get up in recovery room and go out shopping for the day or visiting friends and family rather than going to the hospital or being in bed for days or weeks and missing a lot of work. And how do we achieve that? That's a good question. Well, basically there are a dozen different steps that I use, each of which incrementally helps to diminish the amount of bruising and swelling that the patient has, and that includes the type of anesthesia we use so that when they wake up, they're bright-eyed with a smile on their face, they're feeling good about the procedure, not feeling limited. And I'm conservative, so I still don't want them to go crazy. I don't want them to go out partying the first night after surgery, but it's certainly possible for many of them to even go out to dinner the evening after a breast augmentation procedure. And that's why I love my rapid recovery breast augmentation approach. That is a lot of questions we just answered regarding breast augmentation. I'm sure you have some more. Feel free to send us messages for additional information at the office. And if you're interested in breast implant surgery, our rapid recovery breast augmentation procedure, and our LA Natural approach to getting beautiful results with breast augmentation, I'd love to meet you in person. This is Dr. David Stoker, board certified plastic surgeon in Los Angeles.